Have you ever wondered how we can sing like a diva, or talk the hind legs off a donkey, or beatbox like a legend? Then this is the video for you. In this video, we will be looking at one of the most pivotal and extraordinary pieces of apparatus that has allowed us to communicate effectively with each other. We will be looking at the larynx. In case you didn't know, I'm Tanya Chamberlain from the Division of Anatomy here at the University of Leeds. And in this video, we will be dissecting the anatomy of the voice box. Aside from allowing us to sing like an angel, the voice box or the larynx fulfills several roles, and it is important that we understand what these roles are. The larynx allows us to phonate. That means it allows us to produce sounds that enable effective communication between each other. This could be in the form of spoken word, singing, or grunting at parents, or even beatboxing as previously mentioned. It also acts to protect the airways. Not only are there components that close off the airways and protect us from inhaling food, but the larynx itself is fairly mobile, and the muscles acting on the larynx help to reposition the larynx during swallowing. Additionally, when these systems fail, the larynx helps us forcefully expel air to eject inhaled objects or eradicate infections. I am, of course, talking about coughing. So let's go and look at the learning objectives for today. There are 4 learning objectives that we are going to cover, but there's quite a bit of overlap between them, so don't worry. Firstly, we're going to look at the bigger picture and look at the location of the larynx and its relations with the nasal and oral cavities and the pharynx. We're going to break the larynx down and look at the anatomy of the larynx, including the cartilages, the muscles and the membranes. We will look at the innervations of the larynx before finally looking at how these components work together to allow the larynx to perform its duty. So let's crack on and look at the larynx in situ. You've probably seen this image before, so let's quickly recap the regions that these boxes represent. This is the nasal cavity, the oral cavity, and this large green posterior box represents the pharynx. This can be divided into regions of the pharynx, the most superior being the nasopharynx. Below this is the oropharynx. Below this is the laryngopharynx, and this communicates with the esophagus, allowing for the passage of food into the stomach. So that only leaves this area, the focus of today's topic, the larynx. Let's make this look more like it should, and throw in a sketch of the larynx and the pharynx. So on the right, we can see the anatomy that we need to explore. But let's find some things that we already know. This is the inferior constrictor muscle of the pharynx. We can see the changes of direction of fibres down here. As we move into the esophagus. Anterior to this, we have the larynx that sits superiorly and directly leads us on to the trachea. Before we move on, we should look at the larynx in a cadaver, because it's not quite as easy to see this. So here we are. Can you see the larynx? This might help. Here you can see the larynx sitting anterior to the laryngopharynx and anterosuperior to the esophagus. So let's recollect ourselves and look back at today's learning objectives. So the next thing we need to look at is the anatomy of the larynx, including the membranes, nerves, muscles, and the cartilages of the larynx. Except I lied, because the first cartilage is not a cartilage at all. It's not even part of the larynx, but it has an important role in the larynx, which is why I've included it. We have met this bone before. This is the hyoid bone, the free-floating bone that sits in the neck. There is a pair of extrinsic laryngeal muscles that attach to the hyoid, which we will meet in a short while, and also a couple of large membranes, which is why we cannot escape the hyoid in the room when discussing the larynx. Moving on, let's look at the largest of the cartilages of the larynx. This is the thyroid cartilage, on which the thyroid gland sits. On the image on the left, we can see we are looking at the cartilage from a posterior perspective, with the right side of this image having been cut away to reveal some of the structures that otherwise would have been obscured. The image on the right is looking at the thyroid cartilage from a lateral perspective, with the anterior being here and the posterior being here. On the anterior of the larynx, we have this bulge or this prominence. Because it is of the larynx, this is the laryngeal prominence, or it is also known as the Adam's apple. Being the largest cartilage, let's have a look at a couple of features on the thyroid cartilage. The first one is the superior horn of the thyroid cartilage. The superior horn provides an attachment for the thyrohyoid membrane, whilst the shorter and thicker inferior horn of the thyroid cartilage articulates with the cricoid cartilage below it. We have 2 superior and 2 inferior horns, but the right ones have been cut away to reveal the structures within the larynx. We also have this huge trapdoor that looks a bit like the tongue of a trainer. This epiglottic cartilage is located within the epiglottis and provides the substance required for the hinge-like action to close off the airways and protect them from the inhalation of food. It is attached to the deep surface of the anterior thyroid cartilage by the thyroepiglottic ligament. It is also attached on the infero-anterior surface to the hyoid bone by the hyoepiglottic ligament, which unfortunately is not seen in this image. Below the thyroid cartilage, before the larynx transitions into the trachea, we have the only complete circular ring of cartilage. This is called the cricocartilage, and it is shaped similar to a signet ring. The cricoid cartilage attaches to and directly articulates with the thyroid cartilage. It is attached to the inferior border of the thyroid cartilage via a membrane, which we will look at soon. On top of the cricoid cartilage, we have 2 arytenoid cartilages that are very mobile and act to open and close the vocal folds, allowing us to produce sound amongst other things. They have the ability to abduct relative to each other. This means move away, but they also have the ability to adduct, which means move together. This will become more clear when we look at an animation in a short while. On the back of the arytenoids, we have the location of the muscular attachments, so this is called the muscular process of the arytenoids. The muscles act to open or abduct or close, adduct, the vocal folds. I should use this point to explain that the vocal folds are the anatomical name of what we call in everyday language the vocal cords. Whilst on the anterior of the arytenoids, we have the vocal process, which anchors the vocal folds. The temptation to shout Gryffindor now is unbelievable, but those are not sorting hats on top of the arytenoids. Instead, these are the corniculate cartilages. We have covered the cartilages of the larynx, so let's move forward and look at the membranes. The thyrohyoid membrane does exactly what it says on the tin. It is the membrane that runs between the thyrohyoid cartilage of the larynx and attaches to the inferior border of the hyoid bone. A thickening on the deep anterior surface forms the median thyrohyoid ligament, whilst laterally we have 2 holes, or apertures, called the thyrohyoid apertures. that allow for the transport of the neurovascular bundle to penetrate the intrinsic muscles of the larynx. The membrane that joins the cricoid cartilage to the thyroid cartilage is called the cricothyroid membrane. In the event of an emergency where a patient's airway has closed, piercing the cricothyroid membrane can allow emergency airway access. We do not want to pierce the airways above the level of the cricothyroid membrane, as this could damage the vocal folds, preventing the patient from speaking, coughing, or protecting their airways by other means as discussed at the end of this video. The vocal ligament lies most medially and forms the medial edge of the vocal folds. These are where all the magic happens. These tiny little slivers of tissue allow us to make almost every sound that comes from our mouth or throat, except burping, but that's a whole other topic. So now we've had a look at the ligaments, let's have a look at the other soft tissues of the larynx and the joints or the structures that they form. The cricothyroid joint acts between the thyroid cartilage and the cricoid cartilage. It allows for anterior and posterior movement of the thyroid cartilage to change the tension of the vocal folds. This is for more subtle changes in tone of voice. The cricoarytenoid joint allows for abduction and adduction of the vocal folds. In essence, without these joints, we would barely be able to make any sound, and certainly not a great deal of sound that could be finessed. The movement across these joints depend on the actions of the muscle that cross these joints. The first of which is the oblique arytenoid muscle. And we also have the transverse arytenoid muscles. These interarytenoid muscles act to draw the cartilages together and adduct the vocal folds. That means to close the vocal folds. The oblique and transverse arytenoid muscles are collectively termed adductors of the vocal folds. They both insert into the muscular process of the arytenoid cartilages and are both innervated by the recurrent laryngeal nerves, branches from the left and right vagus nerve or cranial nerve 10. We've seen some adductors, so let's have a look at some abductors. These act to open the vocal folds. The posterior cricoarytenoid muscles are the main abductors of the vocal fold and are therefore responsible for the opening of the glottis. The glottis is the space between the folds that is a continuation of the laryngeal inlet and the trachea. These muscles are really important as they are crucial to breath. In the event one of these muscles or their innervation, the recurrent laryngeal nerve, is damaged, the same side vocal fold can fail to open. This can lead to permanent hoarseness in the voice and respiratory distress under forceful breathing. Interestingly, this is Zeus, my 70-kilogram ball of fluff. He's one of my 4 Leonbergers. Leonbergers are a breed prone to a condition called polyneuropathy, a disruption of the nerves of the body. In Leonbergers, this is largely found to be within the recurrent laryngeal nerve. In the summer of 2022, Zeus started displaying symptoms of laryngeal paralysis. The left recurrent laryngeal nerve had started to become paralysed, and the left vocal fold had failed to open. Thankfully, well versed in Leonbergers, I was able to spot the signs. Zeus's bark had become raspy, and he was tiring easily after a walk or playing with his brother. He was taken to the veterinary hospital where they performed a laryngoscopy, and they were able to see lack of movement in the left vocal fold. During the investigation of Zeus's recurrent laryngeal paralysis, they performed a CT scan of his mediastinum to check for tumours. But why? Well, the recurrent laryngeal nerve takes a bit of a detour on its way to the larynx. The left vagus nerve travels inferiorly to the mediastinum. before it gives off a branch as the recurrent laryngeal nerve. It performs a slingshot manoeuvre around the arch of the aorta and then travels superiorly to the larynx, where it innervates the intrinsic muscles of the larynx. If a tumour develops in the mediastinum, compressing the recurrent laryngeal nerve, this could cause paralysis of the muscles on the left-hand side of the larynx. The right recurrent laryngeal nerve takes a less drastic route, only slingshotting underneath the right subclavian artery before travelling back up to the larynx. The scan was clear, so the cause of the partial laryngeal paralysis was put down to polyneuropathy and not a tumour of the mediastinum. To save Zeus, they performed a tie-back procedure in which they placed the stitch in the left vocal fold to hold it open permanently. And this is him in the car on the way home. Zeus's surgery saved him from laryngeal collapse, meaning that he wouldn't suffocate to death because of failure to open the vocal folds, for which I am very grateful. But performing this surgery has left Zeus vulnerable to aspirational pneumonia. Inhalation of foodstuffs causes severe respiratory infection. Thankfully, with minor adjustments to the food he eats and the way he eats it, Zeus will continue to lead a happy and healthy life, if not with a weird frog-like ribbit instead of a proper bark. After that side note, the last of the muscles we are interested in are the two that act to make fine alterations to the sound we produce. These are the thyroarytenoid muscles and the cricothyroid muscle. The cricothyroid muscle acts to draw the cartilage inferiorly to stretch out the vocal folds for a higher pitched sound, whilst the thyroarytenoid muscle applies further tension to the vocal folds. Both of these are subtle but add tone to our voices, such as when we ask a question or when we sing a high note. All of the muscles we have talked about today are innervated by the recurrent laryngeal nerves, except for that of the cricothyroid muscle, which is innervated by the external laryngeal nerve, another branch of the vagus nerve that branches from the superior laryngeal nerve from the inferior vagal ganglion in the neck. The sensory innervation is also from the same branches, which is nice and easy to remember. Now that was a lot, and we took a few detours on the way, but hopefully that slightly unconventional clinical case will help you to remember the innervations of the larynx. But let's take a step back and recap the learning objectives. We have looked at the location of the larynx within the neck and around the pharynx, and we have looked at the components and the innervations of the larynx with a slight furry detour. But now it's time to look at how these components work together. Here is a superior view of the larynx, and in this animation that I have created, we can see how the arytenoid cartilages are able to articulate in a manner that allows for abduction and adduction of the vocal ligaments, and therefore the vocal folds. The adduction, created by the interarytenoid muscles, as previously said, which are the transverse and oblique arytenoid muscles. This is a really stripped back version and we can't see the full action. But if I colour in the bits of interest before we look at some stills, this will help you to see how the anatomy changes according to the muscle's function. Here we have the same image, with the pink arytenoid cartilages and the medial vocal ligaments. The arytenoids get closer together during adduction, and the vocal folds close, closing off the airway. During abduction, the arytenoids rotate and the space between them increases, allowing the vocal ligaments to slacken and open. This is the resting position of the vocal folds during passive breathing. They are slightly open. You could see the cricoarytenoid membrane has folded over and formed the vocal ligament, which means that the rest of the aperture does not allow air to pass, so air can only pass through the glottis. That's the space between the vocal folds. During forced respiration, such as aerobic exercise or respiratory illness, the glottis widens because the vocal folds have been drawn to the lateral walls by rotation and abduction of the posterior cricoarytenoid muscles. Normal speech is represented here. This could also be called normal phonation. The tension of the cords is relatively high, allowing for inflection in tone. Whilst finally the extreme tension and complete occlusion of the folds allows us to whisper. Air is leaving the posterior space and the words are formed by our mouths. Very little tone can be generated during a whisper because of the nature of the whisper is closing of the folds. Any minor inflections within whisper are generally generated by the shape of our mouths rather than the vocal folds themselves. Well, that's it for phonation, but what about the larynx's other roles, the protection of the airway? In this scan, we can see the action of swallowing. As indicated, we can see the pineapple juice in the mouth and the action of the tongue pushing the liquid through the oral cavity into the oral pharynx. During swallowing, we can see the thyroid muscles pull the larynx superiorly towards the hyoid bone. Simultaneously, the epiglottis is pulled inferiorly by the aryepiglottic muscles and the thyroepiglottic muscle to close off the airway and prevent aspiration during swallowing. But there are also a series of reflexes the larynx acts on to protect the airway. The glottic closure is extremely sensitive to touch, whether that be through aspiration of food or in drowning. In the event we are submerged in water, the vocal folds snap shut to prevent water entering the lungs. We also have a laryngeal cough. When we cough, we normally take in a big breath of air and force out air at a high speed to dislodge whatever is there. However, a laryngeal cough is in response to something that is touching the larynx. If something is sat on the larynx, when we take a big deep breath of air before coughing, we are going to inhale it into the trachea. A laryngeal cough prevents this. The glottis is closed and a small puff of residual air is pushed against the closed vocal folds until enough pressure has built up to expel debris from the larynx. And the final reflex to touch on is the gag reflex. If we prematurely swallow, a gag reflex between the pharynx and the larynx prevents the liquid slipping down the larynx and potentially into the trachea. That was a lot of information, so let's have another look at what we've looked at already. We have visited the location of the larynx, and we have discussed this in relation to the pharynx and the trachea. We have also had a look at the components of the larynx, including the innervation and the role of the recurrent laryngeal nerve, which is where you met Zeus. And finally, we linked this all together and looked at the functions of the larynx during phonation and during the protection role over the rest of the airways.